here, so we can start.
Okay, Jared's here, we can start. All right, so in order to get you guys out for your Friday, this will probably be your quickest presentation, but hopefully you'll learn something about Huntington's. So I'm Amy, I'm one of the outpatient nurse practitioners, and I went to Huntington's update several months ago, which is where this kind of came from. I have no disclosures related to Huntington's, but I am a speaker for AbbVie regarding some migraine medicines, Ubrelvy and Qulipta, if you want to know about that later. All right, so Huntington's disease is something you rarely hear about in your general practice, unless you are neurology or you've in movement disorders, for example. But what it is a neurodegenerative disease, autosomal dominant genetic disorder. And that's a mouthful to say basically it's genetic, and you've got if your one family member has it, you got a 50-50 chance of getting it. And at some point they did figure out, and you'll see this later on as far as where this came from. The CAG repeats were just, hold on a second, were discovered back in the late 1800s. And basically, if I can pull this video up at some point, you'll see basically where your genetic DNA is set out, and that set is repeated abnormally. So we all have that, but when the copies increase, then obviously that's when you start seeing symptoms. So anything above 36 is technically diagnosed as Huntington's, but most of the time you'll see some of the patients will have over 40, most of our patients that we have. And the higher the number, the sooner the symptoms you're gonna see manifest. And we'll talk about that here in a few minutes. But you can see in that picture on the right hand of the bottom screen where that protein is abnormal and how it repeats as far as along the genetic chain. But in the end, it affects the gene regulation and causes the symptoms when that's repeated. So why is this important? So where this protein essentially attacks the brain and where this is effective is in the basal ganglia and of course in the cortex. And if you think about what each area of those brains control, then that's the things that you're going to see and where these patients have problems. So your emotions, your motor learning and control, your speech, if you have, there's a particular type of speech that you'll see with Huntington's later on. And then of course, thoughts and reasoning. And if you think about along the way, what all that affects in your daily life, then once you see a Huntington's patient, then if you're walking down the street and you're looking at people, that are homeless or that have mental health issues, you can sometimes pick those people out. So the characteristics usually come to light in about 30 to 50 years old, sometimes sooner, sometimes later, depending on, like I said, the CAG repeats. And typically you see the abnormal movements, but most of the time these patients present with psychiatric or behavioral issues. So they're in and out of prison. They may, at the younger ages, act up in school, get fired from multiple jobs, have bad relationships. But over the years, that gets worse, or they become incarcerated or hospitalized because of these issues. But ultimately, this disease, unfortunately, is fatal. So 90% of the patients have the chorea or sudden involuntary movements. And the treatments that we have are the tetrabenazine, deutetrabenazine, and Austedo is, of course, the brand name. And then allopurinol, which is an injection that we use, has been very beneficial because, as you'll find out, these patients are very non-compliant. And a lot of that has to do with their executive functioning or lack of executive functioning. You'll see dystonia, bradykinesia, the gait impairment is very obvious. Speech impairment, like I said, they have a very particular type of speech, and swallowing, because essentially they're losing control of everything. I always tend to tell people when I'm trying to just tell them exactly what it is that it's ALS, Parkinson's, and Alzheimer's all in one, because of how it affects all those different areas of the brain. And when people pretty much know those individually, and if you think about a person having all of that, then that's Huntington's. And it's at a much younger age that these people present with. So another area is the cognition and memory. These people have slower processing speed, decreased attention, memory deficits, and of course, planning difficulties. So, going to the store and getting groceries is not something they do because they get distracted. Younger people with this, like in their later high school, early 20s, for example, can't, are seen as ADHD or bipolar even. There's a lot of, misdiagnosis that go on, especially if you don't know if you have that history of Huntington's in your family. In hindsight, people will look back and think, oh my goodness, we saw this 10 years ago and didn't know what it was because of the now visible symptoms that they have. And like I said before, a lot of these people end up in trouble with the law, have poor relationships. So they're, prostitutes, homeless on the street. And because of their impaired judgment, some of them have abuse problems. And then going along with that, as far as mood and behavior, the impulsivity, word finding difficulty, being able to communicate, the depression, aggression, all that kind of stuff. So the suicide risk is one of the main things that we assess for as well, because these people, as you can imagine, they're young, they're in the prime of their, of their life, a lot of them, and all of a sudden they start having issues, whether it's processing. We've had people that are high executives in businesses all of a sudden start having cognition issues. They can't think of what they need to do when they get to work, or aren't able to finish projects. And all of a sudden they can't keep a job, and they're having to look at disability. And because they don't know what this is, a lot of times they lose opportunity to gain that disability, to have any kind of financial help. And because of their previous, poor relationships and family, a lot of them will not have the resources from that support as well. So all of that together, you can imagine that the suicide risk would be higher. And it is, I've read different things, but of course it goes up because we're learning more. And of course the Huntington's numbers are increasing because of testing, but it goes anywhere from 20%, 25% of these patients have suicidal risk. And we do see that. So juvenile onset, we have had 2 patients in our clinic, and I'll talk about that as well, that have juvenile onset. And these are patients that we see as children. And we have, our youngest one right now is 12. We've had one come through, but not follow up, that was 4. They tend to obviously have behaviors, sometimes seizures. The father is usually the one that's positive in the history, but they're usually seen as delayed, developmentally or socially or any of that. But it's a rapid progression. And we have definitely seen that in our one patient. We have seen him now for 2 years, I believe, maybe 3. I get all messed up with COVID, but for pre-COVID, we had just initiated the contact with him. And he is actually adopted, but he has progressed just in this short time, even with medications, because some of the medicines that we give for adults, of course, aren't approved for children. So we're using some different things, but mainly with his communication, he's unable to speak clearly. So we're looking at things to help him with that. He's not able to stay in school because of the behaviors. And physically, he's having issues now with walking. So he will be probably wheelchair bound in the next few months. And then this is just a way of how HD is staged. So the new way of staging is basically once you are positive, that is actually stage 1. So this will probably change in the next few months with some things that are going on now with the HDSA. But the Huntington's disease, if you know it's a family history, then that was initially stage 0. You either have it or you don't know. But once you have the biomarkers for that, then that's stage 1. Well, now stage 0 is going to be basically you have it. So all of that's going to shift. But essentially the 3 stages are, you have it, you start showing symptoms, and then you start declining. And it can be pretty quick depending on how you respond to the different medications. And if, just like any of the other movement disorders, if you start having trouble swallowing and you're aspirating, or you fall and have an injury and you don't recover from it, then obviously that can speed things up. So obviously some of the bigger challenges, I mentioned those, the behavioral health. As you well know, with any kind of behavioral health needs, it is near impossible to have those resources. And because Huntington's is such a rare disease process, most people don't even know what it is. So that hopefully will get better with some publicity, things that are going on. And then, of course, the financial resources and disability. When these people are diagnosed, many times they've been fired or they quit their jobs, if they even have something set up like that. But most of them come to us without insurance and very limited family help. And so if they have not, very little to work from. So that's a huge challenge. And thankfully, there are organizations starting to be able to help with that, but it's just finding those and getting that going. Oh goodness, what did I just do? Okay, so I'm gonna try, I don't know if I can do this. It's probably not gonna do it. Hold that thought. Because I want you to see kind of what this presents like. Oh, my word. Mr. Guy in the booth, can you open this? Can you open this link from up there?
There's a period there with YouTube. Yeah, it's not. That's why it's wanting you to do the browser. Because it's not spelled correctly.
Okay, back up. Sorry. I don't want.
Paste it on.
Well, I'm trying to get it where it'll let me edit that. Here, come help.
Yeah, you'll have to get out of presentation mode.
Slideshow. You take it out.
Yeah, let's see where.
Okay, yeah, go down. Keep going. Keep going right here.
Okay. Let's see if we can. Oh. Well, there it goes.
Hopefully it doesn't bring up anything inappropriate.
I'm sure it'll be
It
blocked.
didn't when we did it in the office, but
Will they block
oh
anything?
no. We're not going to watch 30 minutes worth, as you can see this is, but I want you to see some of the characteristics with Huntington's patients.
Good morning, Rex. Where Mama? Where Mama? Good morning. I want these orange blankets when you die. Can I have them? No. Why not? My hand's cold. Freezing. Right, what do you want to wear? What colour dress? This one?
You can hear her speaking.
Kimberly, or KJ, is in the late stages of Huntington's disease, a rare degenerative brain disorder that has slowly eroded her mental and physical abilities. Rachel also lives with Huntington's. 6 months ago, she could walk without help. KJ and Rachel both live at Peruru in Christchurch. 11 people live here, and they all have Huntington's.
Right, I really need you to do one big start for me so I can get this on.
In its late stages, Huntington's has been described as a combination of Alzheimer's, psychosis, and Parkinson's.
Your arm?
Keep sitting, keep sitting. Use all those tummy muscles.
So you can see how
KJ
difficult it is
and
for her to get her
Rachel
clothes on.
Never get a rest
And that
from
constant
involuntary
moving
movements,
never, the chorea
even
never
while sleeping.
stops.
Yeah, just toward that though.
Huntington's is hereditary. There is no cure.
Huntington's is a very cruel disease. Your child just disappears before your eyes. Your father and I went together, and so I didn't find out until Rachel was around about 15, 16. I had no contact with him all that time anyway. That was really, really scary at the time. That was really quite upsetting. I had no knowledge of it. Things were a bit rough there for a while.
Just do anything.
Yeah. Kimberly inherited it from her biological father.
Makeup? Come on, you look like a crossing today.
She decided to be tested and found out just before 25th birthday that she did carry the gene, and we knew that she would be symptomatic in her late 20s or early 30s.
Good. I look like a trade queen.
I always talked about it to Kimberly every now and then that this disease was in her family and that she might inherit it herself. So when she got to the age where she thought, I might want to settle down and have children, or I don't know what to do, she decided to be tested so she could make plans for her life.
Beautiful. What perfume would you like, KJ?
She was incredible that day. I sort of lost it a bit, and she said, yeah, we've got to make it work, Mum.
Where to now? To the mirror. Don't crack it this morning. Hold on. Hands in. All right, here we go. Don't crack it. All done. Yeah, that's right. She's enjoying herself. She's happy. I think as long as they're happy in life, then that's their biggest goal accomplished.
All right, we'll stop it there. So you can see basic movement, the chorea that is constant, and some of the medications do stop that. But most of the time we come to a time where that essentially stops working and they become bedridden, and then they're receiving total care. So nursing homes or facilities, assisted living even, are very limited in what they can provide because you can see it takes total care. So even in our area, we have, because of the families that we are involved with, we have 3 or 4 different family units that we're now seeing multiples positive with symptoms. There is one nursing home in North Georgia that's been able to take a couple of family members because they've kind of known what to anticipate and expect. We've had one gentleman that we've sent up to, I think it was Indiana. We had him here for, goodness, it was almost a month and a half because he had no family. He would have been, I mean, essentially a ward of the state in his 20s, and we were able to find a place up north that had a Huntington's unit within a facility. So it's very hard to place these patients when they don't have resources. So we have a specific care team here at Erlanger, and I hope I have the right slideshow here, but we are a center of excellence with Vanderbilt through the Huntington's organization, and we focus on the treatment of the symptoms and mainly quality of life. And you can see the different aspects that we see with our clinics. So we meet the first Thursday of the month, and all these different people come and participate in that. The patients, we have anywhere from 10 to 12 that we see on that one day, and we see them basically in groups of time frame and rotate what specialties see these patients. And not all of them are seen by the same ones every time. When they first come to us, the first day is usually 2 or 3 hour visit, but after that, usually within the hour, then they can complete that visit. We have, of course, our movement disorder specialist. Oh, good, it did work. Dr. Ferluga, Dr. Valadez, myself, and Sarah Hines is our licensed social worker that works with our patients doing counseling and also helping with those community resources. This is on our website under movement disorders, and you can resource that if you were to have a patient that you might think need to be seen as well. But we do everything with these patients within the clinic: basic swallow study, the physical therapy assessments, the occupational therapy. We order home health typically, or whatever needs they have for therapy if they can get somewhere, all the medication, help getting the resources to apply for TennCare, all that kind of stuff, to try to give them the best quality of life and to get the best, have the best outcome that they can have. So a lot of things come up when you think about the Huntington's disease in general. Genetic testing, as you know, it being a family disease, most of these people do not know they even have the gene if they have a dysfunctional family, which many of these people do. And then by the time they decide or see that they can have that potential, they have married, had children, and a lot of them, their children have had children. So you're talking about multi-generational affected. And by then it's too late to prevent this. If they catch it or know about it early enough and can do family planning, then, some of us see that benefit as well. Some of them cannot see beyond that. So the question is, when do you do it? Do you do that with children who are at risk? Do you do that before they're 18? Do you wait till they can make that decision? Do you tell your family members, I have HD and you have this potential? Some of them want to know, some of them do not want to know. We have, like I said, multifamily groups now that we're seeing. Some are testing, some are not. Some of them have children and grandchildren, so they're choosing not to, but at the same time, you can see where that benefit can be. But we usually send them to genetics here at Erlanger. Dr. Stevens has been very kind to help with that because they have such an extensive counseling people for that know how to approach it, how to present it before you're ever tested. Unfortunately, sometimes we'll have a primary care doctor go ahead and test a patient, and they're just not ready for that information. And by the time we get them, then they have Googled everything. They know family members who have passed away with this or committed suicide, for example, and they just know that's where they're going to end up. So there's a whole process to that. Yes, question?
Are there any implications for when to test? Could someone get long-term care insurance before they test positive?
Not yet, but there are laws and bills and all that going through Congress and all that you can help pass that will help some of that. Because once you have a diagnosis like this, a lot of times you can't get long-term disability, and they're very limited. So what we usually tell patients, if they come to us with that potential to get that, whether it be long-term or short-term disability with a work situation, before they get that in their medical record. And it's just, it's the game you play to be able to get resources, but that's the logistics of it. But they're working on a way to where once you have that, you'll be able to get more resources. That's a big push with HDSA. So of course, family planning is a big deal. We have a gentleman now that was just diagnosed. His mother, I believe it was, passed away with it. He got tested. He's about to get married, so they're already doing some family planning stuff. And another big issue is a feeding tube. All of these patients end up with some kind of dysphagia along the way. And some have chosen to go ahead and get a feeding tube to supplement so they don't lose weight, so they don't get that far down the pike and have to make a decision, or their family has to make a decision. So it's important for them to have advanced directives as well. But a lot of these patients end up coming to us, and family members cannot make that decision. They want to keep them alive forever, but yet they're going, tunneling down the drain, and the family member has very clear decision on paper. I don't want this, but then they get it. And there's lots of things that come up with that. So there are a lot of clinical trials. sorry about the other error there. These are just a few. There was one, the Connect HD and HD2 have been really big in the HD world. There was one that they really thought was going to lower or inhibit the protein that makes these genes repeat, and of course, therefore prevent the symptoms. And it got stopped because of, I can't remember if it was a side effect or what the actual reason was, but it was a big deal about 2 years ago. And we were at the conference where it was announced that this was going to stop. And a lot of the people there were patients. It was a family oriented session. It was like, I mean, someone had passed away because they were so close to having something that was going to help their quality of life. But you can see the different areas that they're working on, whether it's infusing something into the brain that's going to prevent this, lowering the HD proteins, just helping functional mobility or the chorea, and of course, slowing the CAG expansion. And that was just a few on the HD website that I pulled off that are in phase 2 or 3 that show some promising results. So you think about HD, like I said, lots of us have never heard of it until you get involved. All of our textbooks had maybe a paragraph, or at least in nursing. And unless you did movement disorder, probably in medical school, you maybe didn't see a lot of this unless you had this crossed your way. But these are just some of the societies and organizations that are working on helping get the word out that this is an illness, that there's things, one, for the families and the caregivers to know that there are resources for, but also for those of us who are providing some of this care, resources to learn more about this. So the HDO, the one with the colorful things down here, that's for a youth organization. They have a camp every summer, and that's been huge for the kids. The HD Reach, you'll see on that website that there's a lot of resources just for family, whether it be covering medications, getting equipment, long-term planning, those kinds of things as well. In the study group, you'll see where the patients can get involved in the different clinical trials as well. So the biggest thing that we like to promote is just getting involved. It's hard to pick something, because everybody has a passion. And when you're in movement disorders, there's lots of things. But the center picture is actually of a group of us that did a walk on the river park it's pre-COVID, 5 years ago, probably 3-4 years ago. Very small group, but the center gentleman sitting is one of our patients, but his wife was working here. I don't know if she's still here at the time, but it's a picture of all of us that walk to raise money. And they do this every May is Huntington Disease Awareness Month, but it's also covered up with other awareness months. So it kind of gets overlooked because people don't know what it is. They do multiple fundraisers through town, and typically it's people who are affected by Huntington's that drive these things. Like I said, the center people were the ones that kind of got this together for the walk. There's a gentleman in Chattanooga whose sister was positive, and he helps go around doing fundraisers at different places, restaurants and things. He'll have a night at, like this one up in the corners at the Tap House. We've done other things as well. So now when you look at that, hopefully you'll kind of have an idea of what it is, but how it's important to get involved, and how it's one of the smaller, I think, health issues that is in the world that very few people know. One of the things that Sarah does is go out to our community and talk to firefighters, police departments, and explain to them, because these people, when you see them on the street, as you can see with a different movement, they look intoxicated or impaired of some kind. So it's teaching officers to ask the right questions before they jump the guns to get somebody locked up that doesn't need to be, because it can be very traumatic. I do know people are still doing this, and my son is a Tennessee State Trooper now and just recently finished the academy, and that was part of his training. Someone came in and talked to them about different things they'll be seeing, and Huntington's was one of them. And he had remembered me talking about it. He said, "Do you remember that thing you talked about?" So I thought it was really, really good that at least there are places other than what we're doing here at Erlanger that other people are still working on that. All right, are there any questions? That's just the nitty gritty about Huntington's. Anything else? Yes, ma'am.
When I worked with the geneticists here, the adult one, they had these patients before they were tested, they had to undergo psychological. They had to see a psychologist, a couple times or whatever, but the psychologist had to kind of sign off.
Right.
that They were okay to test. That's still part of the.
As far as I know, it is. And of course, we have our neuropsychologist, Dr. Young, that comes over from Siskin to do a lot of our assessments because the suicide rate is so high. You can imagine getting a diagnosis like that if you're positive, or if you're positive and you pass this on to children or grandchildren, the devastation that can be happening. And that's why it's important to have that. And that's why we don't favor primary care or anybody else doing those tests and given results without that background, because it can be detrimental. Now you know. Mhm. Mhm. I know there's different studies for both, so that if you have symptoms, stopping the progression, but then also doing something with that sequencing before you see the symptoms. Yes, that's been proven, of course, in lab, but yeah, that's what I understand. The experts are not here, let me say. So I was hoping Dr. Ferluga and Dr. Valdez would be present, so if there are any questions, they can ask, but well, thanks. Thank you. Thank you.